I first got connected with Allie when she sent me an email in October 2015. She said, "My academic interests are in contaminant, fate, and transport and implications for human health." As we had a little bit of conversation, she also made clear that she was not as interested in a university faculty career as she was in applying these insights to the world. Well, like many E-IPER PhD students, Allie explored a number of different areas for research, and I identified an opportunity where we had 10 years worth of systematically collected air quality data in Dhaka that we could pair with some systematically collected child respiratory health outcome data. When I first identified this, I thought, oh, this could be kind of a nice master's project for an epidemiology student. They're always kind of looking for projects, and I could see some pretty straightforward analysis. But as Allie was still looking around, I offered that she might want to look at this. And she got interested and she really leveraged the coursework that she had taken from Kristen and others. And I was in both epidemiology and biostatistics. And then I was able to watch what was just really a remarkable process as she gained more and more skills and then thought more deeply about what it was that she was exploring. And she really looked at problems she was analyzing with newer tools, reflected on those implications, and then thought more and just went deeper and deeper. When she was presenting the latest work of her analysis to her committee 2 years ago, with really a level of creativity and sophistication that far transcended what I or any of my collaborators had ever envisioned, I thought, not for the first time, what a remarkable intellect Allie possessed and what a contribution she could make to a university. So in the middle of the committee meeting, I spoke my assessment. And Allie noted that she had begun to realize how much she actually enjoyed the exploration and was giving more thought to the possibility of an academic career. At that point, the whole committee just piled in. Each member of the committee came up to me and noted how much they agreed with my assessment that Allie was really a genuinely remarkable PhD student. So today you get the opportunity to see some of Allie's remarkable skills in careful analysis and communication. But my job today is to introduce Allie, and I've commented a bit on her scientific skills, but my introduction would be incomplete if I only mentioned her scientific skills. You cannot really understand Allie unless you also understand her deep commitment to environmental justice. The intellectual side of these puzzles really engages her, but it's the connection to marginalized communities that motivates her to engage in the first place. So really in the best tradition of E-IPER, she's going to talk about work in Dhaka, Bangladesh, and in the San Joaquin Valley. So I won't take any more time because we're all interested to hear from Allie herself.
Thank you, Steve, for that very kind introduction. And thank you to Kristen for chairing. And thank you all in the audience for attending. I am really excited to share my work on environmental contaminants and health in early life. And I'll talk about my findings related to the health effects of ambient air pollution and chemical contaminants in drinking water. But first, I'd like to start with a story. This is a story about someone I'll call Carmen, who was a participant in one of my research studies to understand water quality in private wells like this one. I worked with partners from a community-based coalition to test Carmen's well water, and we found nitrate concentrations about twice the regulatory limit for drinking water. Now, nitrate is a common contaminant in agricultural areas and a known risk to infant health. So when I called Carmen to tell her this news, she had some very straightforward, reasonable questions, like, can I drink the water? Can my kids drink it? Can I cook with it? What does it mean that I've been drinking this water for years? Now, unfortunately, the honest answer to most of these questions is we don't know. And I'll go into more detail about nitrate later in the presentation. But for now, I want to talk about how we understand the links between environmental contaminants and public health, and why it's so difficult to answer questions like Carmen's and allow people and policymakers to make decisions that are protective of health. So imagine we want to understand the connection between a contaminant, in this case nitrate, and a health outcome. I want to highlight 3 research barriers that make it difficult to quantify this relationship. The first problem is that contaminants tend to occur in mixtures due to common environmental sources, common anthropogenic sources. And because of this, it can be very difficult to disentangle the effect of any single exposure. The second problem is that we often have limited data, both about the occurrence of contaminants in the environment and the behaviors that determine exposure. And finally, both pollution and adverse health outcomes are not equitably distributed. This is true on a global scale. Low-income countries bear a disproportionate burden of pollution, and it's also true on a local scale. Pollution here in the US disproportionately affects marginalized and low-income communities. And this inequity can make it difficult to disentangle the health effects of chemical exposures from other environmental and social stressors. And it can also suppress the voices of the communities with the lived experience of pollution. My dissertation aims to tackle these barriers in two contexts: ambient air pollution in Dhaka, Bangladesh, and drinking water contamination in California. I focus on populations that are vulnerable to chemical exposures, children and pregnant women, and I make methodological contributions to overcome prior research barriers and improve understanding of environmental health risks. Specifically, my dissertation has 4 chapters. In chapter 1, I explore the impact of ambient PM2.5 on child respiratory infection. In chapters 2 and 3, I turn to connections between drinking water contaminants and preterm birth. And in chapter 4, I explore exposure to nitrate and another agricultural contaminant, 1,2,3-trichloropropane, in domestic wells. Now I'm going to focus on just the first 3 chapters today, although I will briefly describe the 4th chapter towards the end of the presentation. Before I go on, I do want to acknowledge that this work was not done alone, and to thank my collaborators at the International Center for Diarrheal Disease Research, Bangladesh, the Atomic Energy Center, Dhaka, the Agua Coalition, and the Community Water Center. And before I dive into the nitty-gritty details, I'm going to give you the big picture of what we found. We found that ambient PM2.5 particulate matter pollution was associated with child pneumonia, but not upper respiratory infection, in Dhaka, Bangladesh. So 2 days after a day with high particulate matter, there was an increased incidence of pneumonia. And we look at a hazy skyline like Dhaka, it might just seem like one type of contamination, but these particles actually come from many different sources, such as biomass burning, coal, and dust. And we found that the relationship between particulate matter and health may depend on the sources of particulate that generate these particulates. The rate of pneumonia was higher among days with more particles from brick kilns, which are shown here in the middle. We also found associations between 2 chemicals in drinking water during pregnancy, arsenic and nitrate, and preterm birth. Now, preterm birth is essentially birth that happens too early, at less than 37 weeks of gestation. And we saw evidence for stronger associations between arsenic and nitrate exposures in the earliest preterm births, less than 32 weeks, which are rare but very severe outcomes. And finally, we found modest associations between even low concentrations of arsenic and nitrate and preterm birth, that is near or below US regulatory limits for drinking water. Now, these findings are exploratory. There are relatively few prior studies on these low concentration exposures and preterm birth, but they do suggest that if future studies confirm these findings, the regulatory limits may need to be reevaluated. So now that you have the big picture, I'll jump into each of the first three chapters of my dissertation. And in each chapter, I'll discuss what is known, the data and methods we use to investigate our research question, and the results and conclusions we draw. So my first chapter explores link between ambient particulate matter air pollution and child respiratory infection, with a focus on the role of the source composition of particulate matter. And this research was in partnership with the International Center for Diarrheal Disease Research, Bangladesh, or ICDDRB, and the Atomic Energy Center, Dhaka. So what is particulate matter? Well, simply put, these are particles in the air. And the smallest of these particles, those less than 2.5 microns in diameter, are called PM2.5. And exposure to PM2.5 is the 5th ranking mortality risk factor worldwide. PM2.5 has also been associated with hospitalizations for respiratory infections among children, and respiratory infections are the leading cause of child mortality worldwide. But the strength of this association in low-income countries like Bangladesh is not well known. And the reason for that has to do with the research barriers I discussed earlier. So first, particulate matter is not just one contaminant. As I mentioned, it's a mixture of particles from different sources. Now, here are the 3 most common sources of particulate matter by mass in Dhaka. And particles with different sources can have different physical and chemical characteristics. So there's been a lot of research interest in understanding the health effects of different components of PM2.5 to understand which sources and industries are most harmful to health. Now, another challenge is that PM2.5 is not equitably distributed. So low-income countries have much higher concentrations. In this map, anything that is not green is greater than the World Health Organization guidelines. Bangladesh, our study area, is located in South Asia, which is a region with high levels of ambient particulate matter. And these regions with the highest burden of pollution also tend to have the highest burden of disease, including child pneumonia. And they tend to be those with the least amount of data on air pollution and health outcomes. So what this means is that existing studies on the relationship between PM2.5 and child respiratory infection largely come from high-income countries like the US, where we have more data, but lower exposure to pollution, lower burden of disease, and different sources of particulate matter. So we wanted to know, first, what is the association between short-term exposure to ambient PM2.5 and incidence of child pneumonia and upper respiratory infection, or URI, in Dhaka? And second, what sources of PM2.5 drive these effects? So starting with the first question. Now, to answer this question, I used data from 2 simultaneous 10-year data collection efforts in Dhaka, PM2.5 monitoring and child health surveillance, which happened to be within 4 kilometers of one another. The health surveillance was conducted in the community of Kamalapur, which is a very densely populated low-income area of Dhaka. And ICDDRB established a free clinic in this community to track child respiratory health in 5,000 households over 10 years, representing 12,000 children and 28,000 clinic visits for pneumonia and URI. But what makes these data so unique is the community-based approach. Study households were visited weekly to check on children's health, and project staff referred any kids with certain clinical signs or symptoms to a free clinic where they were diagnosed and treated by project physicians. So this gives us high confidence that the data represent the actual incidence of pneumonia and URI. Simultaneously, the Atomic Energy Center was measuring PM2.5 at least twice weekly. So each point on this figure represents the average PM2.5 on a given day. And as you can see, there's a strong seasonal trend. And most of the observations are above the World Health Organization guideline of 10 micrograms per cubic meter. Now, our analytical goal was to identify whether on days with high PM2.5, there are also more clinic visits relative to the expected seasonal trend. So if PM2.5 is above this blue trend line, do we see an increase in pneumonia above the trend as well, either on the same day or a few days later? So the broad strokes of our analytical approach are here, and I'm happy to provide more detail by email to those who might be interested. But for now, I'll just note that we adjusted for seasonal trends and weather conditions. And what we're looking at for is the rate ratio, or the ratio of the incidence of pneumonia or URI on days with higher PM2.5 by 10 micrograms per cubic meter. And here are the results. This figure shows the incidence rate ratio and 95% confidence interval for pneumonia at different lag times after exposure. So for example, the first line represents the estimated change in the incidence of pneumonia on the same day as a high PM day, and the bars represent the uncertainty in this measure. Now we see a peak effect 2 days after exposure. So there's about a 3% increase in pneumonia incidence 2 days after a 10 microgram per cubic meter increase in ambient PM2.5. Now for upper respiratory infection, we see a similar peak at lag day 2, but the effect estimates are not statistically significant. So moving on to the second question, what sources of PM 2.5 drive these effects? Well, these are the sources of particulate matter in Dhaka, and these were determined by my collaborators, Dr. Philip Hopke and Bilkis Begum, based on the elemental composition of PM 2.5 on each day. The most common source was biomass burning, followed by brick kilns. The fugitive lead fraction likely comes from lead acid battery recycling facilities, and the zinc source from galvanizing factories. So why not just take the individual source and find the association with our health outcomes? Well, the problem is that these sources are correlated with each other, and they're also correlated with total particulate matter mass, which we've just shown is associated with pneumonia. So we used a novel matching approach. So the goal of this approach was to identify matched sets of days with similar risk factor for respiratory infection, but different PM 2.5 sources. So for example, here we have 2 Wednesdays in December with nearly identical total PM 2.5 mass, similar temperature and humidity. So adjusting for year, we might expect similar rates of pneumonia and URI. But looking at the sources of PM 2.5, we find that the first day has a higher contribution from the zinc plating industry, and the second day has a higher contribution from biomass burning. So we identified over 100 of these matched sets of days, and then we run a similar model as described previously, but now we're looking for the effect of a given PM 2.5 source within these matched sets. And what we found was that the strongest effect estimate was for PM 2.5 from brick kilns, followed by fugitive lead emissions. And these 95% confidence intervals are largely overlapping, and we've lost some power by focusing on these match sets, but we see similar trends for pneumonia and URI. Now, in addition to this matching approach, we also developed a complementary stratification analysis. I don't have time to go into this in detail, but I am happy to follow up. And I'll just note that this approach also suggested that days with the high contribution from brick kilns and lead acid battery particles were most strongly associated with pneumonia. Now, this study has some limitations. As I mentioned, there was about a 4-kilometer distance between the study population and the PM 2.5 measurement site, which is really quite amazing for a low-income country setting, but it does mean that we'll likely miss some of the local sources of pollution and misclassify exposure to some degree. The PM 2.5 measurements were also twice weekly instead of daily, so we can't estimate distributed lagged effects. But both of these limitations probably suggest that we are underestimating the true effect size. So what do we conclude from these studies? Well, first we started a collaboration between multiple organizations to leverage some of the most high quality data available in South Asia to fill a research gap on the health effects of PM 2.5. We found that ambient PM 2.5 was associated with an increase in pneumonia incidence, but not upper respiratory infection, with a 3% increase about two days after an increase in PM 2.5 of 10 micrograms per cubic meter. Now, this might sound small, but there are about 6.4 million cases of pneumonia in Bangladesh each year among children under 5, and over 60 million in South Asia. So a 3% increase could suggest 200,000 additional annual cases per year in Bangladesh alone. And a 10 microgram per cubic meter change in PM 2.5 is really quite modest for a region like Dhaka with high particulate matter. 3% is also approximately double prior estimates of the effect size of pneumonia hospitalizations. And that may be because we're estimating disease incidence. And we're also looking at a young population in a low-income country setting with different risk factors and sources of particulate matter. We developed 2 new exploratory methods to account for correlation in source apportion data. And we found that particles of different source composition may have different impacts on child respiratory health. And the brick kiln industry in particular, we think should be targeted for continued research. And brick kilns are very widespread throughout South Asia. They burn coal to generate bricks for construction, and they often use polluting technologies. So some of the research that is following this in Dr. Luby's lab is aiming to incentivize the use of less polluting types of kilns. Okay, so as we move to chapter 2, we're going to reset and travel from Bangladesh back to California and return to drinking water, which is where we started with the story about Carmen. But instead of nitrate, this chapter investigates arsenic and other naturally occurring metals in association with preterm birth. So starting with these naturally occurring metals, also called geogenic metals. Now, we often think of contamination as something that is caused by humans, and that is often true, but there are contaminants that just exist naturally in the environment. So these geogenic metals are those that are in rocks and minerals in the Earth's crust. And when these rocks make up an aquifer, under certain conditions, the metals can dissolve into groundwater. Now, one of the most well-known geogenic contaminants is arsenic. Arsenic is globally distributed in groundwater, and exposure through drinking water can lead to cancer and other health effects. Some studies also suggest that high concentrations of arsenic in drinking water during pregnancy can increase the risk of adverse birth outcomes, including preterm birth. Now, as I mentioned, preterm birth is birth before 37 weeks of gestation. Preterm birth accounts for 75% of perinatal mortality and has potential health consequences even later in life, including neurodevelopmental and respiratory issues. And it can have a high psychological and financial toll on families. And it's not that uncommon. Around 10% of infants are born preterm, and we still don't fully understand its causes. So certain environmental exposures, including arsenic, have been identified as potential risk factors. But there are only a few prior studies on arsenic and preterm birth, and all have focused on regions with high concentrations of arsenic in groundwater, in drinking water. But arsenic is common here in the US as well. It's usually below regulatory limits, but arsenic was actually the most common cause of drinking water violations in California over the last 20 years, representing about 40% of violations. And it's not alone. Over half of drinking water violations in California were due to geogenic contaminants, including uranium, manganese, and hexavalent chromium. Now, each of these metals has been associated individually with preterm birth in a small number of studies, but the health effects of these metals at low concentrations or in combination are not well understood. So for this study, we wanted to know, what is the association between elevated concentrations of geogenic metals in drinking water and preterm birth? To answer this question, I was very lucky to have access to data on nearly all California births from 2000 to 2011, including birth certificates and hospital discharge records, representing over 6 million births. Now, after excluding those with missing or invalid data, we arrived at a study population of about 5.5 million births, of which 9% were preterm. I also want to take this opportunity to note that I am going to use gendered language throughout this talk with respect to the study population, and I want to acknowledge the gender diversity of people who give birth, including non-binary and transgender parents. Moving into the methods, our first step in this study was to estimate exposure to metals in tap water during pregnancy for each birth. To do this, we used data from community water systems. These are nearly 5,000 public utilities in California that are required to regularly monitor for contaminants. Our approach was to assign each birth to a community water system based on the address of the maternal residence. So if a woman lived within the boundaries of a water system at the time of birth, she was assumed to receive tap water from that system during pregnancy. Then I identified samples collected from that water system during pregnancy to estimate the concentration of metals in tap water. But you can imagine this isn't always straightforward because water samples aren't collected from the tap, and the sources of tap water can look very different for different parts of California. So take San Francisco. This city has just one community water system. It serves about 2.5 million people, and it relies almost entirely on surface water, the majority of which is brought through aqueducts from the Yosemite Valley. So this is the Hetch Hetchy Reservoir. It delivers some of the highest quality tap water in the country to cities in the Bay Area. But the picture can look very different in other parts of the state. This is the community water system for the city of Tulare in the Southern Central Valley, or the San Joaquin Valley, which serves about 65,000 people. This water system relies entirely on groundwater. It has about 24 wells, some of which are treated, and some of which are used without any treatment. So to estimate tap water quality in a system like Tulare, we used flow path data from the Division of Drinking Water to identify which sources are treated and which are used without treatment, or are point of entry into the distribution system. And because there's no data on the flow contributions of these different sources, we relied on the average of the point of entry concentrations to estimate tap water quality for each birth. We found that in general, the concentrations of metals were low and right skewed, so only a small percentage of births had high concentrations of metals in tap water. And because not every metal could be assigned to all births because of sparse monitoring data, we ended up with about half of the study population with complete exposure assessment. So how do we estimate concentrations between metals in tap water and preterm birth? So let's go back to the outcome of preterm birth, which again is birth at less than 37 weeks of gestation. So here we see a hypothetical pregnancy trajectory for 4 women, 3 of whom have a preterm birth. But this isn't really a homogeneous outcome, because you can imagine that a birth at 24 weeks is a much more severe outcome for the health of the child and the mom relative to a birth at 35 or 36 weeks. In fact, preterm birth is often categorized into different levels of severity to better capture the differences in the origins and causes and the prognosis. So our analytical approach relies on something called time to event or survival analysis. And it's called this because it's usually applied to illnesses or deaths. It's designed to investigate whether an exposure accelerates the time to an outcome. So as applied to preterm birth, we see that at any given time in gestation, some of our study subjects will have a preterm birth and others won't. So this analysis is designed to ask whether exposure to metals in drinking water increases the risk of preterm birth at any given time during gestation. And because that association might not be constant throughout pregnancy, we can break up this analysis and look at the risks at different time periods in gestation. In other words, a stepwise analysis. And at this point, it's important to draw attention to the fact that these early preterm births are thankfully very rare. So the majority of preterm births are near term or just 1 to 3 weeks early. So again, the broad strokes of the analytical plan are here. I'll note that we adjust for maternal covariates. We stratify on water system, which essentially allows us to estimate the effect of metals on preterm birth within a given geographic area to better control for socioeconomic factors. And we use a weighting approach to counteract selection bias. You probably noticed we really reduced our sample size by selecting on births with complete exposure. And this weight essentially upweights those births that were less likely to be included in the analysis. And now we're estimating hazard ratios, which is epidemiologists speak for risk. And so that can be interpreted as the hazard or the risk associated with a doubling in metal concentration. So moving to the results, we'll start with arsenic. We found that arsenic was modestly associated with preterm birth. So a doubling in arsenic concentration was associated with a 4% increase in the risk of preterm birth. And this finding was very robust to model specifications like different kinds of adjustment, stratifications, and weighting. Now, as we look at how this association changes across gestational age, we see the effect estimate was significantly higher for very preterm births, from 20 to 27 weeks. Now, none of the other metals in our analysis were significantly associated with preterm birth at any gestational time point. So going back to the results for arsenic, how does this association between arsenic and preterm birth change with gestational age? So we've used a stepwise regression. So what we're actually assuming is that the risk is constant within these gestational age categories, which may not be true. So we wanted to know what the functional form of this relationship might be. And we found that the best fit was for a linear relationship, suggesting that the association between arsenic and preterm birth decreased linearly over gestational age. Now, it's probably a good time to remember that the concentrations of arsenic in drinking water were very low. So about 2% of the study population had arsenic above the regulatory limit of 10 micrograms per liter. So what does this mean for public health? What concentrations of arsenic matter? And we report effect sizes associated with a doubling in arsenic, which it could imply that those low concentrations are important, but is a bit hard to interpret. So we used a flexible modeling approach to explore how the association between arsenic and preterm birth changed across the concentration distribution. And we found that the biggest increase in risk happens between 0 to 10 micrograms per liter. Now, these are still very modest effect sizes, but it does suggest that these low levels of arsenic may be biologically relevant. So getting to the conclusions, we found that arsenic was associated with preterm birth, even for low concentrations at or below regulatory limits. Other geogenic metals did not contribute to the preterm birth risk. Now, the strongest evidence was for an association between arsenic and those earliest preterm births, which again is a severe but rare outcome. And we used a survival analysis approach, which hasn't been widely applied to the outcome of preterm birth, but which is a promising tool to investigate these associations over the course of gestational age. The study also has some limitations. So we exclude private well owners because of the lack of data on water quality. And exposure assessment, even within public water systems, is a real challenge for drinking water. We made some assumptions due to the lack of complete data related to the flow contributions of different sources. We've also assumed that women lived in the same address at the time of birth during the entire pregnancy, which may not be true. And we don't observe changes in exposure during pregnancy. So most of these assumptions would lead us to underestimate associations, suggesting the results may be conservative. And while we've corrected for selection bias with weighting, this isn't a perfect solution, and we still may have residual selection bias. And finally, there may be confounding. We've adjusted for maternal demographic variables, we've stratified by public water systems, but there still may be unobserved exposures or behaviors that correlate with both metal exposure and preterm birth. So in the next chapter, we're going to use a study design that really aims to mitigate this confounding and prioritize internal validity. Now we're going to come almost full circle back to nitrate and investigate whether elevated nitrate in drinking water increases the risk of spontaneous preterm birth. And I'll note this work was recently published in open access, so it can be reviewed online for more detail. So we're going to start, we started with the number one cause of drinking water violations, arsenic, and now we're turning to the second most common cause of drinking water violations, nitrate, and one that's also been increasing in frequency over the last 20 years. Nitrate is a groundwater contaminant like arsenic, but it's anthropogenic, or it comes from human causes, primarily fertilizer application and animal manure. So let's return to the city of Tulare in the San Joaquin Valley and call out what you probably noticed, which is that this city is surrounded by agriculture. And what's a bit harder to see is that there's also nearby confined animal feeding operations, in this case, a dairy operation. In fact, there are many of these dairies and poultry farms throughout the Central Valley. And as I mentioned, these happen to be the primary sources of nitrate inputs to groundwater. So nitrate is most widespread in agricultural regions like the San Joaquin and Salinas valleys. So why are we concerned about nitrate? Well, nitrate can oxidize the iron atom in hemoglobin to generate methemoglobin, which limits the blood's capacity to bind and circulate oxygen. This can lead to infant methemoglobinemia, or blue baby syndrome, which can be fatal in infants. Blue baby syndrome is very rare. It's usually only seen in infants fed formula with high nitrate well water. But the fetus may be vulnerable as well. So fetal hemoglobin is more easily oxidized than adult hemoglobin, and both the fetus and infant have low levels of the enzyme that reduces methemoglobin. So we wanted to know whether nitrate was associated with preterm birth. And we focused specifically on spontaneous preterm birth. So what does this mean? Well, let's go back and add a little more nuance to the outcome of preterm birth, which can actually be subdivided into those that are medically indicated, which is induced or delivered by C-section due to concerns for the health of mom or baby, or spontaneous preterm birth. And these spontaneous preterm births can be further divided into those that are associated with a maternal illness like gestational hypertension and those without, which represent about 40% of preterm births. And we focus on these spontaneous preterm births without maternal illness because for the most part, we don't know what causes them, but hypoxia and oxidative stress are suspected risk factors. We further subdivide this outcome into two categories: early preterm birth from 20 to 31 weeks of gestation, or near term from 32 to 36 weeks, which together represent about 4% of births in the study population. So the data used for this chapter are very similar to the previous chapter. We also use the same exposure assessment methodology to estimate nitrate concentrations in tap water. But there are some key differences in the study design that I'd like to highlight. So in order to quantify the relationship between nitrate and spontaneous preterm birth, we need to consider the issue of confounding that I mentioned in the previous chapter. Now, nitrate, as we know, is an agricultural pollutant that has been shown to disproportionately impact low-income rural communities and communities of color. So there are social stressors that can impact both nitrate exposure and preterm birth, as well as the behaviors that determine exposure. So to deal with this confounding, we used a sibling matched design, also called a within mother design. So instead of comparing outcomes among women with different exposures, we focus on those women whose exposure changes with different pregnancies. In other words, they have discordant exposure. And what we gain by focusing on these cases is that we control by design for maternal structural, genetic, and demographic and socioeconomic factors, even most behaviors which might be expected to be relatively constant across pregnancies. So we start with the same study population, but now we're excluding indicated preterm births, and we exclude non-sibling births, arriving at a sample size of about 1.4 million siblings. Now, one limitation of this sibling design is that parents might choose to move in between pregnancies. So as a secondary analysis, we restrict the sample only to those siblings with addresses in the same water system. So in other words, the mother stayed in the same location, but her water quality changed over time. And this is about as close to an ideal study design or an ideal target trial as we can get. So unlike the previous chapter, we're now going to categorize the exposure into three groups, where high nitrate is considered to be above the US regulatory limit of 10 milligrams per liter as nitrogen. Medium exposure is from 5 to 10 milligrams per liter, and low exposure is less than half the regulatory limit. And discordant exposure would be considered to be switching between these categories. So we found that high nitrate exposure was quite rare in the study population at less than 1%, and 13% of sibling sets had different exposure. So for our analytical approach, we are no longer using a survival analysis framework. Instead, we use conditional logistic regression, which conditions the analysis on mother ID. So we don't need to adjust for maternal demographic covariates. They are already controlled. And this analysis gives us odds ratios, which again is analogous to the risk of the outcome among siblings with high or medium exposure relative to low. So getting to the results. Starting with the findings from medium exposure, we've observed a small association between near-term births, or those from 32 to 36 weeks, and a larger effect estimate for those early preterm births from 20 to 31 weeks, with about a 50% increase in odds or risk of spontaneous preterm birth among siblings with medium exposure relative to low. And when we restrict the sample to those siblings born in the same water system, this is our sort of ideal target trial, we find similar estimates, if a little bit higher. And moving to high nitrate exposure, or nitrate above the regulatory limit, we no longer see a significant association between high exposure and near-term birth, 32 to 36 weeks, but we see a strong association for early preterm birth. So note that the x-axis here is different. So we're now looking at a 250% increase in the odds or risk of early preterm birth among siblings with high exposure relative to low. And similar to prior studies, we did find racial disparities in nitrate exposure in our study population. In particular, there was a higher percentage of Hispanic maternal ethnicity among births with high nitrate exposure. And the highest rates of nitrate exceedance and also the highest rates of preterm birth were found in the San Joaquin Valley. So this study has some similar data limitations with, as the previous chapter with respect to private well owners and exposure misclassification. We've also selected on sibling births, although we found similar effect estimates in an unmatched analysis on the entire sample. And unlike the previous chapter, we've not considered any potential environmental co-exposures like other agricultural contaminants. So as I wrap up and think about these two chapters on water quality, I want to focus on our contributions and what they mean for population health. So in both chapters, we've used methods that haven't been widely applied in the literature, including a survival analysis and a sibling mesh design. And in both chapters, we found significant associations between chemical exposures in drinking water and preterm birth. The highest effect size was for nitrate above regulatory limits and spontaneous preterm births from 20 to 31 weeks, with an odds ratio of about 2.5 or 250% increase in odds. And this is much higher than the hazard ratios we found for arsenic, but recall that the unit of measure is different, so they're not really comparable. On the whole, though, the evidence was strongest for a significant effect of nitrate, given the high internal validity of the within mother design. Now, I do want to emphasize that our findings are exploratory. So these are some of the first studies on nitrate and arsenic in the US and preterm birth. So we really need more research to test these hypotheses in other study populations and with other study designs. Now, we also saw evidence for stronger associations between chemical exposures and the earliest preterm births from less than 32 weeks of gestation. It's important to note that these births are rare, as I mentioned, but they are very severe. So identifying risk factors to prevent them is crucial. Another salient finding was that we found modest associations for preterm birth, even with the low concentrations of nitrate and arsenic in tap water, that is below regulatory limits. Now, currently the regulatory limits for arsenic and nitrate, in fact, most drinking water contaminants, are not designed to protect against preterm birth or other reproductive health impacts because there just isn't a scientific consensus on what those impacts are. And that's why we need more studies on these exposures to generate a body of evidence about the safe limits of these chemicals in drinking water. And even though we saw these low-level relationships, the effect estimates generally increased with concentration. So the strongest evidence was for an impact of nitrate above regulatory limits on early preterm birth and for increasing concentrations of arsenic. So step one is making sure that communities that have these chemical exceedances get clean water to protect against reproductive impacts and all the other known health effects of these contaminants. Our study found that the tap water quality was generally good in the study population. Only about 2% exceeded arsenic limits and less than 1% exceeded nitrate. But this does mask the fact that, first of all, there are racial inequalities in who's being exposed to these high levels. So there's higher exposure among Hispanic residents. And it also masks the most vulnerable population of all, which is domestic well owners. Now, I mentioned that this is a population that is excluded from our studies because there's just very little data on domestic wells. They are unregulated, so it's up to the well owner to get their own information about water quality. And these wells are also often shallow, and they can be very close to the sources of contamination. So this is a dairy I showed earlier, and we can now see that there's a community adjacent that relies on domestic wells. Here's another well surrounded by citrus fields. So these wells are very vulnerable to contamination. And now this brings me back to where we started with the story about Carmen, who is a participant in a study for the 4th chapter of my dissertation. And I'll now just give a very brief overview of this research. In short, we're investigating exposure to nitrate and 1,2,3-trichloropropane, an agricultural contaminant, among domestic well owners in the Central Valley. This was a partnership with the Agua Coalition, or the Asociación de Gente Unida por el Agua, which is a grassroots coalition of community residents dedicated to securing clean water in the San Joaquin Valley, and with the Community Water Center, a nonprofit organization that supports Agua and other community-driven solutions. So as part of this project, we tested water quality in 29 domestic wells in the San Joaquin Valley, and we surveyed well owners about how they use the water for cooking, drinking, and bathing. And then we paired those findings with statistical modeling of groundwater quality to evaluate exposure risk. And over half of the 29 participants in this study had some sort of chemical contamination in drinking water above regulatory limits, and nitrate was the most common. And our statistical learning models also suggest that about half of well owners in the San Joaquin Valley are vulnerable to nitrate or TCP. And the majority of these communities are also in census tracts designated as disadvantaged communities, meaning that they may be facing not only water pollution, but air pollution, economic stress, and other social exposures. But these communities also have the lived experience of pollution and the expertise in what it means for their lives and their health. So as we think about interventions to try to improve water quality, that's where the role of these community leaders like Agua and community-based organizations like the Community Water Center become so crucial. So I was very thankful to have the opportunity to do both quantitative epidemiology research and to partner with community-based groups for my fieldwork. So finally, my dissertation defined connections between contaminants and health. Each chapter made methodological contributions, and each brought us closer to answering questions like Carmen's, improving decision-making around environmental health threats, and ultimately to move towards solutions for safe water in California. So thank you all for your time.
Thank you, Allie. That was a superb talk. So it says, what was the hardest part about your research? That was from an anonymous attendee. So I'm going to ask that for them.
Yeah, that's a good question. I think the hardest part, I think of the PhD in general is finding the research questions. And so I think getting to the point of being able to zero in on drinking water exposures and preterm birth took a good 2 years plus. And then figuring out the right way to answer the question. So that was a real hurdle. But then also in the last year, of course, we've all had some challenges in our research. And just as the pandemic started, I was in the field collecting water samples with community partners from the Agua Coalition. We had to stop our field effort and we had to put everything on hold. And when I went back into the field to finish up the well testing, I wasn't able to have as close connections with their community partners. I was taking samples alone instead of having a team with me because we were trying to reduce exposure. So that was difficult because it felt like it was harder to get the involvement of the community coalition that I really valued. And then having doing report backs with our participants virtually has also been less than ideal. We'd rather go to their homes and share these results in person. But there has been some upsides to the pandemic in terms of, first of all, getting so many people here to attend, but there was also the opportunity to connect our domestic well owners with a program for free bottled water, which was made much more widely available during the pandemic. So that was something that was a challenge, but then also had some silver linings. So thanks for the question.
Yeah, great. We're getting a flood of questions now, so I may have to pick and choose a bit. Daniel, do you want to unmute and ask your question?
Yeah, hi, can you hear me? This is Dan Smith. Allie, congratulations. That was really enlightening. So I was wondering, it sounds like some of your findings are really important in terms of uncovering new relationships about small increases in the contaminants you studied with the preterm birth outcomes. And it sounds a little bit more like how we treat lead right now in the US, which is there's no safe level. So I was wondering, in your perspective, what kind of appetite or windows of opportunity are there for reevaluating the California or EPA water quality standards? And what would be the process for studies like yours to be taken up by those agencies?
Yeah, no, that's a great question. I think it really depends on who you talk to. So I would say that the appetite is stronger in California. I spoke to the former chair of the State Water Resources Control Board, really asking that very question, and with respect to nitrate, and her response was that we need to reevaluate nitrate. We need to consider potentially lower regulatory limits. So, but that's a personal experience, and her optimism about how that might happen was that it is possible, but we would need more research. So I think in California it's more likely to have action relative to the federal level. But what that would look like would be the EPA convening a group to evaluate the state of the literature. And so our studies are adding to that literature, and I think they're providing some of the strongest evidence to date for a potential health effects below current regulatory limits. But they're going to look at the body of evidence, and no one study can sort of prove those causal effects. So that's why I think it's so important to have more research on this area.
Great. And then I'm going to ask David to unmute himself, and also has a question.
Fantastic presentation. So I'm curious, with the sibling study, there might be things about people who have multiple pregnancies that are different than people that have one pregnancy. So how do you think about following up on that research, and what questions remain in terms of trying to figure out if this is in fact like a causal relationship?
Yeah, no, it's a great question. And the sibling design, as you pointed out, does have biases that are magnified by selecting on siblings. So as women move between pregnancies, they may move, their age changes, potentially other exposures change. So first, I'll just note that one thing that I didn't include in this talk was that we did repeat the analysis among the full sample of births in an unmatched design. So we were looking at between mother effects, which are, we're potentially introducing more bias from external confounders, but we are mitigating those biases that are inherent to the sibling design. And we found similar effect sizes. They were slightly smaller, but within the same order of magnitude. So that does give us confidence that this is a finding that is pretty robust between designs. But in terms of next steps for causal inference, I think as I mentioned, it really is a matter of testing these hypotheses and confirming them in other study populations with other types of study designs. As you know, and for those who aren't in the field of epidemiology, in an ideal intervention, we would assign people to be exposed to different nitrate levels. And we, of course, can't do that ethically. But I think there are opportunities to leverage changes in nitrate exposure over time in different communities to try to investigate these associations in other populations. And then I think there's plenty of work to be done on the sort of fundamentals of the sibling analysis and what are those exposures that are changing between pregnancies, both environmental and social. So I hope that some future researchers will start to look at maternal mobility between pregnancies and the implications for environmental epi.
Great, and Heather Williams, if you could read your question.
Allie, hi. It's so good to see this. What amazing work. Thank you so much for this. It's so important. And what is so cool about this research is potentially, people could act on it, authorities can act on it, but also like potentially people can also make decisions to protect themselves, their families. My question is this, one thing that this drew my attention to that I didn't realize was like how much that nitrate can actually vary year to year. And so people may be assuming, oh yeah, our nitrate's fine, when in fact, in a given year, given drought conditions or the condition of the basin, it might vary and it might become unsafe when you get pregnant. And so do you know of any models that can actually predict with any degree of reliability fluctuations in nitrate?
That's a really good question. So there has been a fair amount of work done in predicting nitrate in groundwater, and my own work included, but there's a couple of published studies and also online tools that will show the distribution of nitrate in groundwater. None of those tools or models, as far as I know, are designed to investigate short-term fluctuations. And that can be really difficult when it comes to groundwater conditions generally, because we do tend to have pretty sparse monitoring data from wells. It can be really difficult to go back to the same well regularly and collect those kinds of data. So I think it's an important point. And I think as we are in a changing climate, and as we are so many wells are vulnerable to drought in the San Joaquin Valley and other parts of the state, it is a really important question of what does that mean for contamination, and not just nitrate. I think arsenic as well can have seasonal fluctuations and can be mobilized by overpumping during drought. So that's, I think, an area of future research. I will also note that in public water systems, nitrate is considered a tier 1 contaminant, as sort of the highest tier or the highest risk. And so if there is an exceedance in a public water system, the users are required to be notified within 24 hours. So there should be some mechanism, at least for those who are on public water, to get that information quickly. So maybe we can move to acknowledgements, if that would be okay.
Absolutely, yeah. We're running short on time here, so thanks everyone for the questions. And yeah, Ellie, if I could pass it over to you for the acknowledgements.
Okay. Yes. Yeah. Thank you all for those questions. That was that it's great to be able to share this work, and I do appreciate it. If there were any that I didn't get to, maybe I can look in the chat and follow up by email. So I do want to start with thanking the research participants, because none of this would have been possible without them, and especially the residents of Kamalapur and the San Joaquin Valley who shared their trust and opened their homes, and parents throughout California. I also want to acknowledge the traditional owners of the land where I've lived and worked over the last 5 years, the Ohlone and Yokuts people. And these data collection efforts would not have been possible without my collaborators and the data collection teams at the Community Water Center, AGUA, the ICDDRB, and AECD. So my advisors, I am just really so lucky to have this team. Scott and Steve have been there since day one, have really never wavered in supporting me and my growth as a researcher, and recently putting up with endless conversations about my career path. So I did a lot of exploration over the first 2 years, and Scott was always able to advise on whatever far-flung interest I had, and always have some sort of story that was at least tangentially related. Scott's just, you've always had so much confidence in me, and that's really helped me to have confidence in myself. Steve has this amazing lens through which he can see the world and figure out how to make it better. And that's something that I really will try to emulate, and will always try to emulate. So I've learned so much from Steve in terms of research and teaching and mentorship. Gary is a committee member and advisor for, I guess, 3 years now, and just really trusted me to take on these research questions and guided me through the field of perinatal epi, and been completely just all in supporting me in my career, and being a true mentor. So I'm so grateful. Mike has been my statistical guide, which, as you can see, is maybe a pretty big job, seeing as I cold emailed Mike 3.5 years ago for a meeting, and then I kept emailing, and he was so helpful. So here we are. So I usually come to Mike with some really high level harebrained scheme, and he helps me sort of ground it and get it sorted, and been very supportive of interdisciplinary research. And then Kristen actually taught the first stats class that I ever took. So her courses have been really foundational and really important to my growth as a researcher, also as a writer. So I'm very grateful to her for her help over the years, and for taking on the role of chair. I was really excited when she agreed to step in. So the Stanford staff, and especially the E-IPER staff, it's been a really crazy time to manage a research program over the last year and change. And so I really appreciate your support and all of your hard work. There's been some folks at the State Division of Drinking Water who were really very helpful in helping me to access data and understand how water is managed in California. So I thank them for their time. And of course, my funders. The student communities at Stanford are just incredible. I mean, my E-IPER cohort, just such wise and smart and generous people. The Luby lab, the Fendorf lab, and too many folks to name. And also friends old and new from outside Stanford who've helped me to have adventures and remember that there is life outside of the PhD. And my best friend, David, who's always been there throughout the whole PhD, and then very literally in the same room as me for the last year. So always, there with good advice and love and support. So I'm very grateful for this journey we've had together. And my family, I think it's because of them that I am here in every sense of the phrase. So rain or shine, they have been there with love and good advice. And so I'm just very lucky. And then finally, my grandfather, John Sherris, who was a big part of my PhD, though he didn't get to see the end, just an amazingly kind and generous and funny and smart person, and grandfather who I always look up to. So thank you all for attending, and be well.